Dental e-conference for the month of May 2023 will be on radiation protection. The presenter is Dr. Swathi from the Department of Old Medicine and Radiology, Saram Dental College, Ramapuram. What is radiation protection? Radiation protection, sometimes known as radiological protection, is defined by the International Atomic Energy Agency as the protection of people from the harmful effects of exposure to ionizing radiation and the means for achieving this. This association also states that the accepted understanding of the term radiation protection is restricted to people. So why do you think radiation protection is necessary? We all know that radiation as such is a double-edged sword, offering diagnosis therapeutic advantages as well as can cause harmful effects through effects of biological ionizing effects of radiation. It can cause some kind of biological damage by creating free radicals and oxidative damage. So what are the general guiding principles of radiation safety? It is to increase the distance between the source and the personnel, usage of protective barriers, reduction of exposure factors and unnecessary radiography, usage of radiation monitoring device, X-ray beam filtration and proper shielding of the tube head, and the age and gender of involved personnel should also be taken into consideration. Coming to the sources of radiation, the natural source of radiation constitutes to about 83%, while the artificial radiation constitutes to about 17% of the total radiation. Looking at the pie chart, we can see that radon is released from the ground. It has the major 55% amount of radiation. We have space radiation, which includes the sun and cosmic rays, the ultraviolet rays, internal radionuclides, like foods containing uranium and thorium, terrestrial radiation, exposure from radioactive nuclides, the soil, like potassium-14 and radioactive decay products of uranium-238 and thorium-238. As you can see in this pie chart, the medical radiology, it's mentioned here, constitutes around 15% of the artificial source of radiation, or 0.53 millisieverts. The important principle of radiation protection will be the distance and the position rule, which involves the operator and the patient. Once after exposing, the operator should stand at an angulation of 90 to 135 degrees and 6 feet from central X-ray beam to prevent any further radiological damage from the harmful effects of ionizing radiation. The guidelines instituted by the National Council for Radiation Protection, the National Council of Radiation Protection recommends a diagnostic reference level of 1.6 milligray entrance skin dose for intraoral periapical and biplane radiography and 1.2 milligray for the intraoral radiography. What are the methods of exposure and reduction? It involves the patient selection criteria, something called as dose justification, optimization for the patient, whether the patient actually requires a diagnostic radiology or whether the clinical diagnosis is enough for the patient. Professional judgment, radiographic selection criteria, basically assessing the risk versus benefits. The conduct of examination, again the choice of equipment, how well the quality assurance is maintained, the choice of technique, operation of equipment, process and interpretation of radiographic image. So this picture shows some of the protective barriers that can be used by the operator as well as the patient to prevent or shield from the harmful effects of radiation. So it involves a lead apron and a thyroid collar. And we also have position indicating devices to orient the X-ray beam. And we can also use many X-ray film holders or aiming rings by using the paralleling angle technique to prevent any further risk of radiation. Following a proper technique when it comes to intraoral angulation techniques, it's preferable to follow the paralleling angle technique or the right angle technique compared to the bisecting angle technique, where the paralleling angle technique involves the image film or the receptor placed parallel to the long axis of the tooth, and the central X-ray beam is directed 90 degrees to the image receptor and the tooth. It is indicated for the maximum diagnostic accuracy. Elongation, spoon cuts, and foreshortenings are avoided. Measurements, length estimations, visibility of structures, and reduced radiation usage. Whereas the bisecting angle technique can involve placing the receptor close to the tooth. The operator or the patient has to hold the film while exposure, which can actually increase the risk of radiation. However, in cases of low palatal height, a bisecting angle technique is still preferred with using adequate radiation protection measures, such as the lead glove. Now, what is this dosimetry? Dosimetry involves determining the quantity of radiation exposure or dose. Dose is the amount of energy absorbed per unit mass at site of interest. And exposure is the measure of radiation based on its ability to produce ionization air under the standard conditions of temperature and air. The SI unit of exposure is the air thermal, and the traditional unit is Röntgen. After Röntgen, who found the discovery of X-rays on the 9th of 8th November 1897. So here we have thermoluminescent dosimetry badges, some kind of personal monitoring devices. This badge has to be owned by the radiologist or the radiographer, the operator basically, and it will monitor the amount of absorbed dose, and it is sent to the Council of Radiation Protection for a periodic monitoring so that the diagnostic or the occupational exposure is within the safe threshold limits. So this is the schematic representation of the badge. It has an open window, a plastic, a cadmium, a thin copper material, a thick copper as well, and lead for absorbing the radiation. Linear non-threshold hypothesis. So what do we mean by this? It states that there's a linear relationship between the radiation dose and the risk factor of induction of a new cancer can occur even at very low doses. According to this hypothesis, there is actually no threshold limit or safe dose below which there is no added risk for radiobiological damage. So as you can see in this graph, so this is observations at a high dose and this is the low dose region. So it is proportionately increases, but still there is no threshold or cutoff limit. Then we can induce the state of cancer even at low or threshold, safe threshold doses. There is a risk of radiobiological damage. So what are the three guiding principles of radiation protection? This involves dose justification, optimization, and limitation. Justification is identifying situations where the benefit of diagnostic exposure likely exceeds the risk of potential harm, assessing the risk versus benefit ratio, whether the patient actually requires a radiological examination. Optimization involves the principle of ALARA, which stands for as low as reasonably achievable. The exposure to the ionizing radiation should be kept as low as possible for maximum diagnostic efficiency. Dose limitation, providing dose limits for occupational and public exposure to ensure that there is no individuals are exposed to unacceptably high doses, which poses a risk of radiobiological damage. So these are the three guiding principles of radiological protection, which involves dose justification, optimization, and limitation. Other methods by which we can actually prevent further radiobiological damage or methods of radiation protection involves the selection criteria, as I told, determining the type and frequency of radiographic examinations. Multiple exposures have to be avoided for the patient. Usage of a high-speed film like E or F-speed film compared to a D-speed, a lower-speed film, using digital sensors, which actually have minimal exposure time. Usage of holders to support the film intraorally. Remember that the film holding should not be done by the patient as well as the operator because there will be unnecessary exposure to the fingers. Exposure to be made with 60 to 70 kilovoltage peak machine. Usage of open-ended, long open-ended image cylinders, rectangular collimation, periapical and biting images, usage of lead aprons and thyroid collars, following the position and distance rule, usage of time temperature film processing, automatic processors compared to the manual methods, usage of radar screens for panoramic and cephalometric when it comes to extraoral film or skull imaging, usage of digital imaging, and reducing the CBCT to the view or field of view or the region of interest. Nowadays, we have specific size CBCT where we can actually take it to that region of interest to avoid radiation exposure to the other sites. The periodic maintenance is called as quality assurance. It's the program for periodic assessment of the performance of all parts of the radiological procedure. It is to ensure a dental office consistently produces high quality images with minimum exposure to patients as well as personnel. The timeline here is the maximum the diagnostic efficiency, minimal the radiation risk is always the guiding principle of radiation protection. So what are the 5 steps to achieve a quality assurance? Is determining to what to monitor, formulate criteria and standards, obtain necessary information, construct a monitoring system, and bring about a behavioral change for the overall well-being of the patient as well as the operator. Thank you.